Postpartum complications. We're going to be looking at hemorrhage, infection, thrombophlebitis, and psychological complications. First is hemorrhage. When assessing postpartum hemorrhage, we're looking at things like fundal height and the tone of the fundus. Is it firm? Is it boggy? We're looking at the amount and the color and the consistency of the vaginal bleeding. Is it red? Are there clots? Are there not clots? We're looking at signs of hypovolemic shock, so we're looking at the vital signs. Development of coagulation problems. Is this mother entering DIC? And we're looking for signs of anemia. There are multiple causes for postpartum hemorrhage. And if we take the list that's here and break it down into early versus late. Early meaning these are hemorrhages that occur within the first 24 hours. Late meaning these are hemorrhages that occur after 24 hours, and it can occur anytime within the first month, actually, although it most usually occurs within the first 10 days. And then we're looking at DIC, which can occur somewhere along that spectrum. It depends. Did she have some kind of condition during pregnancy that she was actually starting the DIC process during the late pregnancy, during the delivery process? Then we're going to see an early hemorrhage. Is this something that really starts going with the delivery and incomplete uterine emptying? Maybe we'll see a late hemorrhage. So DIC kind of crosses between the two. But early hemorrhage, usually it's because of uterine atony, which means no fundal tone, no uterine tone. The muscle is just relaxed and it's not contracting as it should. Or it can be from cervical lacerations, vaginal lacerations, or perineal lacerations. So there's some kind of slow bleeding that's going on, or maybe not so slow bleeding going on, but it's happening within the first 24 hours. Late, after the first 24 hours, well, that can be caused by something was left in the uterus. Retained placental fragments are quite often what we're talking about here. And that, think about it, if you have a piece of the placenta left, that's a piece of the uterus that cannot contract adequately and pinch off those blood vessels, so you've got bleeding in there. It may be slowly building up, and then behind that placental fragment or whatever, and then later it breaks loose and you see the frank blood coming out of the vagina. Or it may be because of infection. There's some kind of infectious process going on. It's an inflammatory process that's going on because of the infection, and the uterus cannot involute properly. We have subinvolution with both of these. The uterus is not properly contracting. That's subinvolution. So what do we see? We see excessive or bright red bleeding. They're filling pads quite quickly, a pad an hour, that kind of thing. That's too much. We see abnormal clots. A couple clots every now and then is not a big deal. Or first time the woman stands up in the morning, that first morning after having the baby, we see quite a lot of blood coming out. That's usually because of gravity. It's stuff that has collected in the vagina. Now she stands up and it all falls out. Well, in this case we're looking at continued excessive bleeding and continued passing of clots. And the other thing is persistent bleeding even though the uterus is firm. We've done some massage, the uterus is firm, and we're still getting this too much bleeding. The alternative is sometimes the fundus doesn't respond and the fundus stays boggy even though you're massaging. And the fundus rises in the abdomen. We also might see some kind of unusual pelvic discomfort or backache. The uterus is filling with blood. It hasn't passed out of the cervix yet, but it's filling with blood and causing pressure, and that's causing discomfort. Or there may be hematoma formation, which you'll see in the perineal area, that bulging, shiny skin. There's some pictures in your textbook about that. Finally, these are the signs of shock you're looking for, right? The early passing into this hypovolemic state. The heart's working harder to try and keep the blood that's in the circulation circulating, so you see an increased pulse and a decreased blood pressure. So what are you going to do about it? Uterine massage if it's boggy. You don't necessarily massage a firm uterus. You massage a boggy uterus. You encourage frequent emptying of the bladder. Try and get her to void. If not, use a catheter. A bladder that is filling will push the uterus out of position and increase the bleeding, because the uterus can't contract if it's not in the normal position. Vascular access. If she doesn't have an IV and she's having a hemorrhage, she needs one. So get the IV started. We're looking for abnormalities in the hematocrit level. You might want to know what her hematocrit was before she entered this process. And as you're starting that IV, draw some blood. Put some blood in a tube, a hematocrit tube. You're going to assess urinary output. Now, that does have to do with what was up here earlier about emptying the bladder. Is she really voiding a lot? Is she voiding just a little? Could the urine, the full bladder, be part of the problem? And helping her to rest. Once this is all over, she's going to have not as much blood. She's going to be tired. Let's help her to maintain her rest. Safety. Once this is over, she is going to be anemic. She has low blood volume, so she's likely to have orthostatic hypotension. So teaching her how to stand up slowly rather than rising quickly. We don't want her to get faint. And that until all of this resolves and her blood volume increases again, she needs to be sitting down while she's holding the baby, not up walking around. Teaching her things about diet, high iron content in the food, what foods to look for, what signs and symptoms of continued problem with bleedings to look for, what does the normal lochia look like, and what should she look for in terms of hemorrhage. And telling her clearly what she can expect in terms of the fatigue, and it's going to take a little bit longer for you to get back on your feet because of all of this. Why did it happen? What she should be looking for. There are several medications that are used. I'm sending you back to your texts for these. Oxytocin, which is also known as Pitocin. Methyl ergonovine maleate, commonly called Methergin, or ergonovine maleate, which is Ergotrate, prostaglandins, which are commonly, we call them Hemabate or Cytotec. All of these stimulate uterine contractions. Now, some of them will also affect the blood pressure. Might be nice to know which ones are going to cause problems for people who are already hypotensive. That was a hint. And some of them may cause some issues by not only causing uterine contractions but also affecting the GI system. So look those up too. See what the side effects are with these drugs.